Thank you, Doctor. I must thank Dr. Dinesh for giving this opportunity to share my opinion. And the topic given to me is the pattern of fundus fluorescent angiography. No punish interest, please. And to start with the basic understanding of the anatomy, the vasculature of the anatomy, it's been divided into two parts, the vascular retina and the avascular retina. And then the vessels, the superficial, they are bigger vessels, the capillaries are deeper, up till the inner nuclear layer, and beyond that it's the avascular part. And the vessels, beyond that is the choriocapillaries and the choroidal vessels. As already been mentioned, choriocapillaries, they are permeable, not other vessels. And to understand better the vasculature of the retina, and the choriocapillaries, they are permeable to the free-bound this fluorescent. Otherwise, we have two barriers. Inner being retinal capillary, blood retinal barriers, the retinal capillaries. The outer being the zonal occludens in the retinal pigment epithelium. The leakage from the choriocapillary would not let it go across by the RP and the zonal occludens, the adhesions, but the impaired permeability of the vessels can make this dye leak out of the normal vessels. Fundus angiography, general principles as already been discussed: excitation, emission, filter, photographic technique, phase of the normal angiogram, cause of the dark appearance of the fovea, hyper and hypo. That's what we are going to discuss now. And the filters, which has been already covered, is we have a blue excitation filter and the yellow-green barrier filters. So you have a better view of the fluorescence. And not to miss, we have a wavelength which is overlapping between the excitation and the emission. A common pattern we see here is the hyperfluorescence and the hyperfluorescence, pseudo or autofluorescence and the transmitted fluorescence. I'll start with the causes of the hyperfluorescence: the window defect, unmasking of the choroidal vasculature, pooling. You have to have some space for the pooling, leakage from the vessels of the choroid, retina, and the disc. Any abnormal vessel itself. Causes of the hypo, blocked fluorescence by the pigment, blood or exudate, any pathology in front of that vasculature, and obstruction of the circulation or loss of the vasculature tissue itself. Normally in radiography, pseudofluorescence and the autofluorescence is because of the overlap of the wavelength of these abnormally chosen filters. It is usually seen in the Ducens, choriocapillary scar, like geographical atrophy, maculopathy like in bullseye, or macular hole. Pseudofluorescence, a red-free photograph with a fluorescence filter without injecting dye, dark subretinal hemorrhage, and a pale C-shaped lesion, dehemoglobinized blood, showing hypofluorescence in the early and the late phase with a dehemoglobinized area very faintly fluorescent. Normally seen, the cause of the dark appearance of the fovea is the avascularity, blockade of the background choroidal fluorescence by increased density of the xanthophyll, or the tall RP cells with more melanin therein. Xanthine is going to block it, and the defect is going to make it a more appearance. Coming to the hypofluorescence, the vascular occlusion, capillary non-perfusion like venous occlusion, loss of the vascular tissue, choroideremia and high myopia, pre-retinal hemorrhage causing hyperfluorescence, blockage of all retinal choroidal fluorescence. Hemorrhage is located in the most retinal layer from ILM to outer nuclear layer. Flame-shaped hemorrhage spironasal to fovea due to branch vein occlusion. Angiograms showing irregular hyperfluorescence blockade due to the hemorrhage. Anatomical layout in the picture A is the subretinal hemorrhage between photoreceptors and the RPE. What we see in the thermoscopically is a scattered area of the hemorrhage, but angiography would show blocked choroidal fluorescence and visible retinal vessels behind the being deep in the location. So here the anatomical layout of the vasculature is going to help us. The A showing a hypertrophic RPE, chirpy we call this, well demarcated hypopigmented area, and the marked hyperfluorescence of the choroid due to blocked fluorescence. Choroid nevus, B and C showing hyperfluorescence corresponding to area of the nevus. Optic pit with a cystic edema in the macula due to maculocysis detachment from the optic pit. Early phase of the arteriovenous phase showing hyperfluorescence of the disc in the area of the pit due to absence of the tissue and the vessel. Late phase shows dark area of the pit. Advanced choroideremia with a large choroidal vasculature can be seen as pale irregular lines. Early phase shows filling of the large choroidal vessels and the retinal vessels but no choriocapillaries. Late phase again showing large choroidal and the retinal vessels and few choriocapillaries at the periphery. Hyperfluorescence, the RPE window defect, like in bullseye, or pooling of the dye itself under RBE, pigment epithelial detachment. Under sensory retina, central serous retinopathy, we have different patterns in the depending on the area location. Causes of the hyperfluorescence 2 is the leakage of the dye into sensory retina, associated macular edema from new vessels, choroidal neovascularization. Prolonged dye retention staining, we call this, associated with the ablutions. BRVO with a hemorrhage in the retinal whitening and a cottonwood spots in picture A. B shows normal fluorescence of the superior portion and a subretinal hyperfluorescence of the inferior portion due to retinal capillaries non-perfusion. Very bright hyperfluorescence